Hi, thanks very much everyone for joining us for this week's Advanced Echo Teaching in the Critically Ill. Very excited to have Vishal talk to us presenting this topic. And I know we've gone through this last year, but it's a cracking lecture. And I think it's really useful for the guys who are starting off doing transesophageal echoes. So Vishal, thanks very much for taking us through this. Vishal is one of our staff specialists here at Nepean ICU. He's one of our reporting echo doctors and recently got his DDU. Congratulations again on that, Vishal. Yeah, over to you, buddy. Thank you very much for doing this talk again.
Thanks, Sam. This is one of my favorite topics, and because when I started this echo career, I didn't understand anything at all, and I spent some bit of time on mitral valve, and after that, I will not say that I understand everything, but I know a little bit about mitral valve. So before talking about the mitral valve prolapse, I think it's very, very important to understand mitral valve anatomy. So I'm going to spend some time on that. And after that, we're going to discuss about mitral valve sonographic anatomy. And then we'll talk about all the features of mitral valve prolapse, and then we'll discuss a few cases. So mitral valve has 5 components. So to start with, can you see my mouse on the screen?
Yeah, we can see your mouse. Thanks.
Okay. So mitral annulus. So you can see there's a round structure. After that, there's 2 leaflets, anterior and posterior. So 2 commissures. Then there's the chordae tendinis, which is attached to the papillary muscles, which is attached to the LV endocardium. So we'll talk about one by one all the structures. So the first, mitral annulus. So you can see this is a fibroelastic ring, which looks like saddle shape, and it encircles the whole valve orifice. And its shape varies. So it's elliptical in systole and it's a circular in diastole. So which is very interesting. And you can see on this is anterior because this is aortic valve, which is anterior structure. And on the lateral side is the left atrial appendage. So wherever there's a left atrial appendage, that's lateral side. And then whenever there's an aortic valve, that's anterior. So in terms of leaflets, so as we know, 2 leaflets, anterior and posterior. And anterior, it's the larger and thicker leaflet. But it just covers the 1/3 of the ring of the valve orifice. But it has very, very strong anatomical support as compared to posterior. And it has 3 scallops, A1, A2, and A3. Whereas posterior, it's a thinner and more flexible structure, but it covers the 2/3 of the ring. Its anatomical support is not great. And that's why posterior prolapse are more common than the anterior. And if you talk about posterior, especially P2 has the weakest anatomical support. So that's why P2 prolapse is most common prolapse as compared to all other mitral valve leaflets. And commissures, anterior posterior and posterior medial, so straightforward. And these are the specific site where leaflet inserts the mitral annulus. So chordae tendini, so these are fibrous strings, normally around a couple of centimeters and 1 to 2 millimeter thick. So this is the papillary muscles, this is the leaflet. So it attaches to the specific portion of the mitral leaflet and to the papillary muscles tips. So there are 3 types of chordae tendinis, so primary, secondary, and tertiary. So the primary or marginal over here, so it attaches at the leaflet tips and it helps in making the coaptation line. If there's a failure to this primary chordae tendini, so there would be problem with the coaptation and there would be significant regurg. And this is the secondary, which attaches the mid level. And so if there's rupture of this basal or secondary chordae tendini, it may not affect the coaptation line, or there may not be any regurg. Whereas the tertiary, it's mainly again, it will not affect if there's any prolapse or rupture to this chordae tendini. It's mainly the support structure. There may be elongated tendon or something, but there may not be any regurg again. So that's why primary cauda tendon is most important. Then papillary muscles. So two papillary muscles, anterior lateral and posterior medial. And normally it attaches at the apical third and the middle third of the left ventricles. And let's talk about sonographic mitral valvulopathy, which is where the money is. So these are the two views, surgeon's view and sonographic view. And when during the surgery, so when surgeons they're looking at the valve, so this is, it will look like this. So there's no change in anterior or posterior, but there's a change in lateral and medial. So again, so where there's aortic valve, that's anterior. Where there's a left atrial appendage, that's a lateral. So, but we will be talking about the sonographic view, which we normally see it during our echoes. Again, so as I said, wherever there's aortic valve, that's anterior. Sometimes there's no aortic valve, and it's not easy to identify which leaflet we are talking about. So my rule of thumb is that if I can see aortic valve, that's anterior structure. If there's no aortic valve, I always look for the right ventricle. And again, right ventricle is anterior structure. So the leaflet, whichever is closer to aortic valve or the right ventricle, that's anterior, and other one would be posterior. And again, if you can see the left atrial appendage, that's a lateral structure. And A1, P1 is closer to the left atrial appendage. So whatever the lateral side, that would be A1, P1. So A1, P1 is lateral. A3, P3 is medial. So again, aortic valve, right ventricle, that's anterior structure. And if you can see the left atrial appendage, that's the lateral side. So that's how we can identify which, if it's A1, P1 or it's anterior posterior. So we're going to talk about a few examples. So let's talk about parasternal short axis view, which is the most straightforward view. And so again, towards the aortic valve, so that's anterior, other one is posterior. And this is the view which has all the scallops. And so this is the left atrial appendage. So that's why this should be A1 or P1. So on the short axis, this is mitral valve view. And you can see all the scallops in one view. So A1, A2, A3, P1, P2, P3. So A1, P1, lateral structure. A3, P3 is a medial structure. And parasternal long axis. So here we are cutting the leaflets at 90-degree angle. So because if you remember parasternal long axis to short axis, we move our probe by 90 degree. So we'll be cutting your leaflets at 90 degree. And so let's talk about this view. So on the top there's a right ventricle, and this is the aortic valve. So this leaflet, because it's closer to aortic valve or the right ventricle, so that's why it has to be anterior. And other one would be posterior. Because we know we are cutting down at 90 degree through A to P2. So that's why this is A2 and other one is P2. So always look for what is anterior structure. That will tell you which is anterior, which is posterior. And you just need to remember that how we cut the plane when we are doing the echo in terms of short axis and long axis. Then the apical fourth chamber. So in the parasternal long axis, we were cutting at 90 degree, but now we are cutting through like this. So we are going through P1, A2, and A3. So let's talk about apical fourth chamber. So there's four chambers, so there's no aortic valve. So that's why, because there's no aortic valve, I'll look for right ventricle. So this is the right ventricle here. So because this structure is closer to the right ventricle, so that's why it has to be anterior. And other one would be posterior. And because of this relation, we know we are going through the P1, A2, A3. That's why this posterior one scallop is P1, and the anterior scallops are A2 and A3. And all these are just a guidance. It's not black and white, and it's not straightforward that it has to be A2, A3, because it all depends on your probe orientation as well. Because if you move a little bit anterior or posterior, the scallops would change. So for example, if I'm cutting through here, and if I'll just move the probe a little bit posterior, instead of A2, I can cut through the P1, P2 as well. So it's just it's a guidance that what it should be, but again, it would depends on your probe's orientation as well. Then apical 2-chamber. So in the 4-chamber, we were cutting down from like P1, A2, A3, but in the 2-chamber, we are cutting down here P1, A2, and P3. So just to remember, I just my mnemonic just to remember it. Apical 2-chamber. So I've highlighted it in red. So A2. So A2 comes in between, and other one is the posterior. So remember P1, A2, A3, apical 2 chambers. So in the center A2, then P1, P3. It just you can make your own mnemonics, but it helps me to remember that A2 comes in between of P1, P3 in apical 2 chambers. So this is to summarize. So we started with parasternal short axis. So all the scallops we can see. Then we're cutting down at 90 degree, which is A2, P2. Then we're cutting down here P1, A2, A3. Then A2 in between in apical 2 chamber, P1, A2, P3. So I think transthoracic echo, identifying scallops are not that difficult, but the tricky part is the transesophageal echo, which we are going to go through. So these are all the views of transesophageal echo. But again, this is just guidance, because a little bit of change in your probe, or whether it's antiflex or retroflex, your scallops may change. Let's go through one by one. So to start with mid-esophageal 4-chamber view. So we're cutting at 0 degree, or you can say 180 degree. So we're cutting here 0 degree. So because we're cutting through 0 degree, so again we're going through A2 and P2. So this is your esophageal 4-chamber view up to 0 to 20 degree. Again, I don't know which one is which leaflet. Let's look for the right ventricle. So the right ventricle is here. That's why it has to be anterior. Other one is posterior. And because we're cutting down in the center, that's why A2 and P2. Then mid-esophageal commissural view. So commissural view, we are at 60 degree. So 60 degree, we are cutting down here like this. And just, normally how I remind myself that your parasternal long axis view is equal to mid-esophageal 4-chamber, A2 and P2. And whereas your commissural view, it's equal to your apical 2-chamber view. So that was, A2 was coming in between. So P1, A2, P3. So mitral commissural view is the same as that of apical 2-chamber. So again, P1, A2, P3. I know it's getting confusing, but so apical 2-chamber is equal to your commissural view. So P1, A2, P3. Whereas parasternal long axis was your equal to mid-esophageal 4-chamber view, which was A2, P2. Then we move to 90 degree. So 90 degree, so first thing, you can see on the 90 degree, you can see some, atrial appendage on this side. So that's why, it would be, A1 would be closer to left atrial appendage. And how I remember it, that which leaflet it would be. So in the 2-chamber view, you can see all the scallops of anterior valve, but a little bit of posterior one. So this is the one you can see all the 3 scallops of anterior leaflet, A1, A2, A3, but a little bit of posterior, because left atrial appendage on this side, so this has to be P3. So lateral side A1 or P1, or medial side is P3 or A3. This is anterior leaflet, so closer to left atrial appendage, A1, because it's away, it's a medial, that's why it has to be P3. And the long axis view is the same that of parasternal long axis, cutting down at 120 degree. And because this is close to the aortic valve, so that's why it has to be A2. Other one is P2. It's just the reverse of the esophageal 4-chamber. making sense so far? I'm not sure I'm confusing you more or it's making sense. And this is, Sam taught us, a couple of years ago that how you orient your hand in understanding all the scallops of mitral valve when you're doing the transesophageal echo. So Sam, any comment on that? I think you're the right person to comment on that. It's your hand.
Yeah, I love this one, but I don't know that the audience is feeling exactly the same way as I do. Because I like this because, if you're holding your left hand, you've got to imagine you're looking down on it. As you said, it's the surgical view. And then the anterior leaflet is the bit above your thumb, and the posterior leaflets are the one below it. And then if you start at 0 degrees, that's your right hand just in plane. And then you can start figuring out where you're looking at it from 0, 60, 90, 120. So again, it's a bit similar to using the toe thing with your hand. I just like having a cheat when you're thinking about your hand structure. But I think whatever works for you is the way to go. I think you explained it very well, Vishal. But yeah, I like this one. Just to remember that it's like you're looking down on your own valve. And you're looking down into that, and that's 0, 60, 90, 120. Choose whatever works for you.
So now we'll try to guess few leaflets, and we'll do it together. And I know it's just beginning of for few people, but we'll go through it. We'll work it through, and we'll try to guess it together. Okay. Louis, let's start with you.
So this look, I'm not sure whether this is the mid-esophageal 4-chamber or 2-chamber.
Is it 0 degrees? You got the.
Oh, that's where it is. I couldn't see it. Okay, so that must be the 4-chamber.
Mm-hmm.
So on the left is the anterior leaflet, on the right is the posterior leaflet.
That's correct.
And we are looking at, God, I've just forgotten. I'm going to
It's a zoomed view. It's a zoomed view. That's why you can't see anything here, but this is your right ventricle and right atrium coming here.
Yeah.
On the side.
So, going to say A1, A2, and P1. No.
So in the esophageal 4-chamber, if you remember, we are cutting at 0 degree or 180 degree, and we are going to A to P2, and this is the same as that of parasternal long axis. So you're correct. This is anterior. This is posterior, but we're cutting at the center. So that's why it should be A2. So in the 4-chamber, we only see A2 and P2 scallops.
Thank you.
Thank you. I'm not sure who is online.
You've got Kalpana, I think, is there, and Sibgat. I'm not sure if you
Do you want to try this one?
We've got Adam and Deshani and Bridie here as well.
Okay, Adam, for you.
Okay. Look, I don't know my toe that well, but this looks like a toe, short axis. And so on the left, we've got the anterior leaflet, and on the right, we have the posterior leaflet.
And can you tell us how you know that that's your anterior?
The right ventricle is on the left.
Beautiful. And what about the size of the anterior to the posterior?
So the anterior leaflet is shorter but wider.
Yeah, nice. And so it's a much bigger leaflet.
And in terms of and you can see all scallops here. A1, A2, A3, P1, P2, P3.
And the arrow is on at what scallop?
It's moving, so the scallops, the lateral scallop is the 1. It starts at 1.
Yeah.
And given closer to We've said that would be anterior, so that we're at the anterolateral, which would be 1. Is that correct or not?
That's
So
correct. It's
P1.
P1.
Yeah.
Very
Nice
nice.
one.
Really nice.
Nicely done. Dashani.
Oh, okay. All right, so we're at, I think, in the commissural view.
Yes, yeah.
Near esophageal, and it's at 56 degrees, so I can see the left atrial appendage. So this.
So let's talk about anterior and posterior first.
Okay, sure, yeah. Which one's anterior, which one's posterior? I guess this is like the 2-chamber, yeah?
Yeah, nice.
How can I tell?
So
'Cause
maybe
where's
think
the
about
RVB?
which wall is wall is on the left and which wall is on the right for the
Yeah, we did
ventricle.
just cover this, didn't
We
we?
did just go through this morning.
All right, this is going to take some thinking for me.
You're all right. This is what it's all about.
Okay, so this is the 2-chamber. Okay, one's anterior, one's inferior.
Very good. Yep.
Which one's the anterior? So the one that is so opposite to the left. So the one on the left is the anterior.
Inferior on the left, and
And the one-
anterior on the right.
Anterior on the right. Okay. So the posterior leaflets would be on the left and the anterior leaflets would be on the right. Other way around?
No, you're sort of getting there. Which ones is it? Ones or the 3s that are next door to the left atrial appendage?
Left atrial
It's the other way to think
appendage,
about it.
The 3. Just said this like 2 seconds ago.
So it's complicated. Keep it. It's
P1, yeah.
It's a lateral structure, the left atrial appendages.
yeah.
So maybe think.
Okay, yeah. So
Just
the
look-
ones is the one nearest to the atrial appendage.
Very good.
Nice.
Why
And
didn't you
so
ask me that one, Vishal?
Yeah.
I can ask you the next one if you want. So this is the posterior. So if you remember your commissural view, I said it's equal to your apical 2-chamber. So A2. So A2 comes between the posterior. And because this is closer to the left atrial appendage, so that's why there should be 1 because it's a posterior. So P1.
Right.
Brady.
Okay, so it's a toe picture. That's very similar to Adam's. In fact, I can take an image. So the anterior leaflet is on the left
Nice.
and the posterior is on the right.
Good job.
Yep.
Numbering from 1, 2, 3 is bottom to top,
Good job.
and it's pointing to the middle two, anterior or posterior, I'm not sure. A2 or P2, I should say.
So this is anterior, as I mentioned before, and you mentioned, bigger one anterior, smaller one posterior, and it's in the dead center, in the center. So P2. Nice. Anyone online, Sigit or Kalpana?
I think this
Sorry.
this one is the middle one actually, and this is again the commercial view of
Yeah.
toe. So it will be A2.
Nice. Good job, Kalpana.
Nice.
Okay, Sigit, this for you.
I guess beginning at the top. So this is again looking at the, so this is mid esophageal view at 0 degrees. So it should be the 4-chamber view, but this is zoomed in. This leaflet should be P2.
Good job. Nicely done.
Great job.
And the last one, again, Louis, for you then.
All right, well, if you've already, that's A2, looks like A2. But I don't
Yep.
know where your arrows
Yeah,
are.
yeah, you're correct. You're correct.
Big vague.
It's correct. It's correct. Okay, so these were the leaflets. So I thought, that was a little bit of fun in guessing all these leaflets. I think, you do more and more and more, I think then it will look easy. But, it's not easy to remember, all the leaflets or scallops all the time. That's why more you do, more you remember. And whenever you see it on the toe, I always try to ask myself what I'm looking at. Then that's how I remember it. Okay, now let's talk about some features of mitral valve prolapse. So what is prolapse? So prolapse, especially mitral valve, so there's a posterior displacement. So this is a posterior displacement of some part of the mitral valve leaflet or the whole leaflet beyond this mitral valve annulus plane into the left atrium. So this should be at least 2 millimeters during systole. And that's how you define mitral valve prolapse. An important thing is the mitral valve, your leaflet tip should be pointing towards your apex, left ventricle apex. So posterior displacement, at least 2 millimeters, and this tip towards the left ventricle. And it could be with or without some mitral valve thickening. So how would you differentiate it from flare? So the important thing to differentiate between prolapse and flare is the direction of the leaflet. So if your mitral valve leaflet tip is towards the apex, it is prolapse. If your tip is away from the apex or towards the left atrium, that's a flare. And normally flare is associated with torn chordae or ruptured papillary muscle, and that's normally the cause of acute and severe mitral regurg. So mitral valve prolapse, so 3 types: myxomatous and mitral valve prolapse syndrome and secondary. So let's quickly go through the definitions. So myxomatous mitral valve disease is also known as chronic or primary mitral valve prolapse. So normally in the male, middle-aged males, 40 to 70 years of age, could be familial, non-familial, can be related to connective tissue disorders like Marfan's, and normally is characterized by increased redundancy or thickening of bearing portion of the leaflet. Whereas mitral valve prolapse syndrome, it's also known as non-classic MVPs, and normally you can see it in young females. And normally they present with simple mid-systolic plaque, and they can be features of MR or there's no MR. And normally most of the time they are asymptomatic. And again, the displacement, we'll talk about these definitions in next few slides. And whereas in secondary mitral valve prolapse, the important thing is it's also known as hemodynamic or functional prolapse. The important thing is there's no problem with the mitral valve as such. From the morphology or anatomy point of view, there's no problem with the mitral valve. But there's either change in the mitral valve, the left ventricle cavity, or there's reduction or alteration in the cavity size due to various problems such as coronary artery disease, rheumatic heart disease, cardiomyopathy, hypovolemia, some shunt. So because of all these things, there could be change in hemodynamics of the mitral valve, which can cause a prolapse. And as we know, this is the most common cause of isolated MR, and patient can be symptomatic, asymptomatic, and they can present with simple because of someone heard the systolic murmur or systolic click, or they can present with all the features of mitral regurg. So let's talk about some echocardiographic features. So let's talk about M mode. So M mode can be very useful for few things in mitral valve prolapse. So on the left side, this is the normal anatomy. So this is the diastole, and this is systole. This is systole. So E wave, A wave, and over here your mitral valve is closing during systole. And in mitral valve prolapse, so this line shouldn't be closing completely. So we can see this is your posterior leaflet prolapsing, and on the right side, both the leaflets are prolapsing. So we don't use MOD very common, but sometimes it can be very useful, especially if you want to measure this distance, because in the 2D mode, because it's a very, very small distance and it's not easy to measure, but in the in the M mode, so this distance you can measure it comparatively more accurately than the 2D mode. So again, if it's more than 2 millimeter, so that is the definition of prolapse. And in terms of definition of the distance point of view, so for the anterior, so normally we do all these measurements in parasternal long axis. That's the standard view. We do all these measurements, and in the parasternal long axis, again 2 millimeter displacement. But if you choose that you want to do it apical 4-chamber, then it's not 2 millimeter for anterior. So it should be more than 1 centimeter at least for the anterior mitral valve prolapse. And normally it's not accepted definition. So that's why I always try to do in parasternal long axis if you can, or toe. But for posterior, it's only the more than 2 millimeter in long axis or any other views. But most preferred view is parasternal long axis. And other features of the mitral valve disease in terms of there could be thickening of leaflet, there could be atrial fibrillation or some atrial dilatation, and all the features of MR in terms of volume overload pattern of left ventricle and the dilation of the left atrium. And as I mentioned in my previous slides, that posterior leaflet it doesn't have strong anatomical support, so posterior prolapse is more common, especially P2. And in the Doppler, the direction of the regurg is very, very important, because that's always the first clue which will tell you whether we are dealing with anterior prolapse or posterior prolapse, because it's always other way around. In the anteriorly directed MR jet, it's the posterior prolapse, and the other way around. And normally regurg is late systolic in the prolapse situation. Okay, now let's go through few cases. Louis, should we start with you?
Okay.
So 52-year-old gentleman, no previous cardiac history, and he presents with new onset atrial fibrillation. And by the way, all these cases are from Sam's library. So thanks, Sam.
Okay, so it looks like if we just talk about the mitral valve.
No, let's talk about everything.
Oh, all right. The right ventricle looks a reasonable size. The aortic valve is opening well. The left atrium is probably dilated, judging by its relative size compared to the aorta. And the mitral valve leaflets do not look completely normal. But
And which scallops we are talking about? Which scallops we are talking about?
So we're talking about A2, P2.
Thank you.
And look, so they're obviously this is a talk about mitral valve prolapse. So there probably is prolapse. And it looks like.
And the first one, I put the normal one actually. So
No,
just kidding.
Because there's mitral regurgitation.
Yeah.
If it was directed, it's kind of the mitral regurgitation direction is I find it hard to tell whether it's actually directed posteriorly. I would expect it to hit the posterior wall if it was true posterior.
not-
So
I
guess
agree, it's not classical. Yeah.
yeah. So it looks like I think it's probably the anterior mitral valve leaflet that's more than 2 millimeters below the annulus.
Sure. Let's have a look in others. I think there's no added information on this, so I'll go to the next one.
Well, except that the regurgitant jet appears to be coming from the middle portion of the mitral valve.
Yeah.
So that would suggest that it's either going to be however, on this view, it looks like it's the posterior that's dipping backwards. So that would suggest it's actually P2.
So what scallops we are looking at, Lois?
Hang on, you did tell me, didn't you? P2A2.
No, so that was
P2,
passed on long axis, and this is now via apical four-chamber.
P3A1A2. I'm really just guessing.
The other.
P1A2A3.
That's correct.
So it looks like actually looks like the posterior is coming back at this point,
Yeah.
which would suggest that it's going to be sorry, P1. P1.
Yeah.
P1.
And we can, and about the regurg.
Two.
On the top.
So that's now directed anteriorly.
Nice. And any other comments on the 2D view on the left side?
So the left atrium looks quite enlarged.
Yeah.
No, can't say anything else. So this is a parasternal long zoom view. So now it looks like it's a posterior prolapse, which would be
Which scallop?
what?
Which scallop based on this view?
P2.
Thank you. And this is the measurement you can see. And it's 10 millimeter or 1 centimeter. So to summarize, Lois?
So to summarize, well, we didn't really get all the views of the ventricles, but this is
All these are the
mitral
important
valve.
ones.
What?
These are the important views. Well, you can get the answers. Yeah.
Mitral valve prolapse involving predominantly the P2 scallop with an anteriorly directed jet, looking like moderate regurgitation at least.
Or you can say P1 or P2 or both, because based on the apical four-chamber, that was suggestive of P1 as well.
Yeah, but see, the problem is that when you get the prolapse, sometimes what you'll see is the bit that's prolapsing, but the other part of, so say P1 might have been normal and we see P2 prolapsing in that view because it
Exactly.
moved out of line. So
And
I'm
to
not,
to be certain, what should be your next step then?
well, if I was really concerned, I'd do a toe.
Yes. So that's what I was trying to make this point, that based on transthoracic echo, it's very, very difficult to identify which scallop we are talking about. So, to be certain, toe is the answer. So next step should be toe, because looks like, on the fourth chamber, there could be P1 as well, but looks like P2 is more convincing. But I think this patient needs toe to get all the answers. Nicely done, boys. Thank you.
Except I can't remember the scallops before chamber view. Shit. All right.
Adam, do you want to give it a try?
Okay.
So 78-year gentleman and history of some atrial fibrillation, some SCC of scalp, and presented with Streptococcus milroy bacteremia. And the question was MR or QA infective endocarditis. And this was one of my summative assessment.
Okay, so we're looking at transesophageal echo forward chamber view on the left and right. So looks to me like the posterior leaflet seems to be I can't be sure whether the tip is actually pointing down towards the apex or whether it's pointing into the atrium. But certainly it doesn't look normal, the posterior leaflet. I don't know if I'm meant to be able to see the tip of it, just in terms of flail versus prolapse.
If you look at the one on the left,
Sorry?
if you look at the one on the left there, you don't, do you think that points towards
On the right, you mean?
No, the one on the left.
This one.
Just look at the 2D one. Can you see that sort of?
So it looks flail.
Yeah.
Yeah. Yeah, I think it looks more flail-like than prolapsing. Okay. That's confirmed my suspicion.
And I think, and maybe just maybe just a good point for the exams, that I think you've got to say what you see. You
Yeah.
can't overreach. That'll be our first comment, because you've got to, you know, for I think for reporting echoes, you've got to be relatively conservative. You've got to say what you see, but you also can't sit on the fence.
Okay.
And that means I don't think we can't say mild to moderate. We can't say moderate to severe. Sonographers are allowed to do that when we're reporting, but we have to make a call. And so you've got to make a decision somewhere in this. And I think that's probably, particularly for the DDU exam, I guess confabulation can give over the appearance of uncertainty. And in the exam, you've just got to do the basics extremely well. And obviously,
And-
I'm not having a go and sort of trying to say how it goes in the future.
Yeah.
Cool.
I mean, look, yeah.
Any other differentials, Adam?
Differentials. I guess there could be a little, is it possible there's a little vegetation there? I mean, I don't know.
Nice, because again, I think stem is very, very important because there's a bacteremia, so we have to consider that as well.
And so on the color Doppler, I mean, it looks like there's a lot of regurgitation, and it's directed towards the right side, so anteriorly directed regurgitation.
Yeah. And sorry, and Alan, can you remind us what scallops you'll be looking at?
Okay. So in the forward chamber, it will be A1, P2, P3.
So 4-chamber, 0 degree, you're cutting in the middle.
Oh, sorry, P1, A2, A3.
P2, P2.
Is it? Sorry. Okay. Fair enough.
So we're cutting down the center. So
Transthoracic. Okay. All right.
Yeah.
Well,
okay.
as you've said, that's P2 then. Not sure what else.
This is
The left atrium looks larger, I suppose, but I'm not used to looking at toe pictures.
Yeah, fair enough.
I can't see that's quality of its spontaneous echo contrast or it's just quick projection, I'm saying.
Yeah. We'll give you
I
better.
think it's the same view, but it's a zoomed view. So I think we can go to the next one.
Is this the same patient?
Yep.
So is this a 2-chamber? I don't know the toe, sorry, I don't know the
Exactly right.
toe images that well yet,
Yeah.
exactly what the name of the whole thing is, but it looks like a 2-chamber.
Yeah,
Um,
it's not very pretty 2-chamber, but yes, it is.
yeah, so
It's not too bad.
in the 2-chamber, we will have the, from the right, it'll be P1, A2, P3. So that looks.
So that's a 60-degree. So, you know, what you're saying, that's 60-degree commercial view. In the 2-chamber 90-degree, you know, if you remember, this is the only view where we can see all the scallops of anterior, A1, A2, A3, and a little bit of posterior, which is P3. So P3, A1, A2, A3, that's our standard view we see at 90-degree 2-chamber.
Okay, so we had some P2 involvement before, now we have some P3 involvement. And again, it looks, the tip seems to be pointing towards the atrium, confirming our suspicion of flail rather than prolapse. This looks like a 3-chamber view. Is that right?
Yeah.
So, okay, so the aortic valve is there, so that'll be anterior, whatever it is. So the anterior leaflet looks okay. And the posterior leaflet again looks like it's pointing into the atrium there. And that, I mean, I can't remember. I'm presuming that's the same as the 3-chamber for the transthoracic.
That's correct.
So that would be P2.
And to summarize,
so we've got severe mitral regurgitations with what appears to be a flail, severe mitral anteriorly directed mitral regurgitation from what appears to be a flail leaflet involving P2 and P3 with, you know, left atrial.
thanks, Adam. Nice. And but in the formal report, we have added there's a possibility of vegetation as well, because I think there's some independent motion we were able to see on few slices. So because of, if there was no bacteremia, probably we wouldn't have said that. But because of bacteremia, and there was some independent motion in few slices, like you can see on this one as well. So we said prolapse, possibility of flail, but there's some vegetation as well on the posterior leaflet.
Well, you had all three. Wait, I thought we can't sit on the fence. So prolapse, flail, and vegetation. Okay.
Good. Can we go back to the color Doppler very quickly, to Vishal? So Adam, you said that there was severe MR.
I'm just guessing, to be honest.
No, you're absolutely right. Maybe just go back one more. Yeah, one more. Just play that. Yeah, nice. So we said there was severe MR, and I've read the guidelines, and they talk about it needing for the color Doppler to fill more than 60% of the left atrium.
Okay.
But that doesn't happen in this. Why is that? I mean, it is severe MR, I completely agree, but why is the color Doppler not filling the left atrium? And the reason I'm asking this question is it's really important that we know the limitations of each modality when we're assessing valve severity. And when a valve, whether it's stenosis or regurgitation, is particularly regurgitation, when it's more than moderate, we need to do multiple interrogations with different modalities because color Doppler cannot be trusted alone. And this is a really good example of that.
I presume we're just not catching the maximum.
Let's say that we are catching the maximum.
And my two guesses would be either it's because it's just eccentric or because it's so severe.
Nice, it's because it's eccentric. And why does, when you've got an eccentric jet, do you not see a lot of color Doppler being formed?
Because of the angle to the
Coander effect.
Because of the Coander effect. So that's the buzzword, is the Coander effect.
Okay,
Now, I'm not an engineer, obviously, but I think the Coander effect is what makes planes fly. It's when you get movement of air over the airplane wing, right? One side of it is bigger than the other. When you get air flying over a wing at speed, or you get water going past a structure, you get I think there's some form of kinetic energy is transferred into a resistance thing. So it's like the air sticks to the wing, and here we've got the blood sticking to the side wall. So that means that you get instead of having big turbulent blood flow, it just skirts the wall because there is an attractive force. On an aeroplane, when the air's got to go over a larger area on one side versus the other, that means that more kinetic energy is transferred into this attractive force, and that's what generates lift. Yeah. So the Coanda effect is this fluid, or the process where you have blood flow sticks to a side wall, and therefore you don't get a lot of turbulent blood flow. Okay, so the buzzword when you're seeing an eccentric jet, you can't rely on the color Doppler because of the Coanda effect. Okay. Thanks, Vishal. Sorry to interrupt.
No, thanks. And I think we have 5 more minutes.
Already got time for one more.
Okay, so Ben, for you.
Say it.
Apparently that's how Dyson vacuums work.
Through the Coanda effect. Oh, that's awesome. I'm definitely stealing that.
Okay, Ben, do you wanna go through it as well?
Update. Yeah, absolutely.
Oh, is this my favorite case ever?
Yes, it's just, from Sam's library. This is amazing.
Okay.
This is going to be.
So this is my favorite case ever, because I just want to say this was maybe 3 years ago where we had our Echo Fellows were joining us. They were both people who had never been to the unit, and we had 2 Echo Fellows that year. And they both come from these sort of quite prestigious units. And on day one, they turned up, and this was our first case that happened on day one. Literally, I'm just showing them around, and then this lady has a Met call and comes to the unit, and it's an absolute cracker. And I think they probably thought that everything was going to be like that for the rest of their time, but it obviously wasn't. But, it's just a good one for day one of an Echo Fellowship. Go for it. Did you get the stem?
Post-anstemi and hypotensive, I think was the stem, wasn't it?
Yeah.
Do you wanna?
Right. Right. Okay, yeah. Okay, yeah, gotcha. Right. So I've got 2 screens, with the only difference between the 2 being color Doppler on the one on my right. I'm looking at a parasternal long axis view that's cut reasonably well. The most striking finding is what appears to be abnormal motion of the mitral valve. This is in the setting of there being relative preserved left ventricular systolic function. I need to interrogate multiple views. The aortic valve looks to be functioning well. I'm not looking at the color one yet. And the RV looks fine. There's the appearance of a significant amount of B lines coming up the posterior aspect of the pericardium, suggesting she's in acute cardiopulmonary edema.
Excellent.
Looking at the color Doppler, what I can see in the shot is mitral regurgitation that's posteriorly directed, suggestive of an anterior leaflet pathology, but I need to see in further views. So I now like to go and have a look at a parasternal short axis panning from the apex up to the base, if possible. So I've got that. Thank you. So I've got parasternal short axis views where the one on the screen left, I think, is at the papillary level, and the one at the right is at the valvular level. The most striking finding on both these images is the appearance of abnormal septal motion with, I like to slow it down to confirm it's in both systole and diastole. However, it certainly appears to be at least in systole, suggesting a right ventricular pressure overload. With regards to the mitral valve, I'd like to put color Doppler over the top, but I can't quite pick abnormal motion in what I can see. So I'm not getting a lot of additional information from this view. In terms of regional wall motion abnormalities, the other thing I'm looking for, the septal segments at the mid and valvular level may be hypokinetic and being pulled rather than thickening, but the inferior anterior appear to be thickening well, and I can't see the lateral wall because of artifact from the top of the throat.
Vishal, just hold that 1 sec. Go back one. Sorry. Just, yeah, just have a look at that.
Sorry, what I'm looking at, the
Regional wall. The cover over that top part with
I'll
you,
cover the top and look at the bottom. Yeah, gotcha.
and then compare that to that one at the top. Just to get you on the right track. The septal movement's okay, just,
Settlement's okay.
yeah, it's probably just, it's not coming out brilliantly, it's pretty jumpy, Vishal.
Right, okay.
Okay. I'll go to the next one.
So.
So yeah, inferior, the inferior
Inferior
section
down.
was down.
So looking at apical four-chamber view over both color on the one on the right. Most striking finding, the most striking findings are one, some hypokinesis of the basal and mid septum that I can see. The appearance of, I suspect a ruptured papillary muscle that's attached to the anterior papillary muscle. I suspect is ruptured. And then looking with probably mildly reduced left ventricular systolic function with regard and an enlarged left atrium with regards to the color Doppler. What I can see here is severe mitral regurgitation that's posteriorly directed. There's the appearance of almost catching the command effect visually with the way that jet's sticking to the wall. From here, I'd like to go on and further interrogate one, the severity of the MR, and two, the nature of that papillary muscle, which I couldn't see very well on the short axis views. So with regards to the mitral regurgitation, switch to a two-chamber, that's fine. So what I can see here again is further evidence that that is a ruptured papillary muscle. I can still see it in this view, suggesting it was not an artifact of what in orthogonal views. There is some inferior, probably almost akinesis in the base, the mid hypokinetic there. And then on the color Doppler again, I've just got torrential mitral regurgitation. It's a very broad jet that's extending through the length of the left atrium and probably going back into the pulmonary veins. I'd like to interrogate with pulse wave Doppler to confirm that.
So Ben, do you want to summarize it for us?
Certainly, it was a 65. So we're a 65-year-old woman who's developed acute hypotension due to developing presumably acute severe mitral regurgitation from a ruptured anterior papillary muscle, and as a consequence, effectively a flail leaflet, anterior mitral valve leaflet.
Oh, so good. What coronary artery is affected?
Probably the right coronary artery.
So how does that give you the
It's
anterior?
anterior. It'll be anterior segments. Probably the left anterior coronary artery, right? I need to know what
That's your answer to that.
Yeah, nice.
So I think it's pretty important in terms of understanding the coronary supply as well. And in the anterolateral papillary muscle, so there's a dual supply from LAD and left circumflex. Whereas posterior medial, there's only one supply, posterior descending arterial Parsi branch, or sometimes from circumflex. So that's why patients with coronary artery disease, acute RCA occlusion can cause, this thing, which was the case, here. So it was pretty impressive case, and we send the patient for urgent cardiothoracic surgery.
And what's great about this case is the example says the anterior mitral valve leaflet was buggered up, which is why you said the anterolateral. But don't forget that both papillary muscles send things to both papillary, both scallops.
Yeah.
So it's just a really nice example of a single blood supply. It was the RCA, it was left circumflex, which was in this patient, I think, and hence the posterior medial papillary muscle went, but it was just the anterior that was affected.
Yes. Okay.
Okay.
Did you think on those original short axis views you could see that papillary? Could we go back to those short axis?
Absolutely. You see it flicking around.
The first ones, I thought that posterior muscle didn't look
Yeah.
completely on that side there. So Is that-
Yeah, I'll
like,
show you,
this is
maybe I'll
the little
show you
flicker
the
that-
pictures on the, you can actually see the anterolateral one is intact and the posterior medial is missing.
I don't know, there just seems to be some weird motion.
Yeah.
Yeah,
it's
it heads up from
There.
So the anterolateral's in place and it's the posterior.
9
medial as
o'clock
well.
to 10 o'clock.
Okay, guys, I think we are running out of time here, so I'll
Vishal,
skip the
thank
last.
you.
I just,
I think we're out of time, buddy.
Sure. And just the last slide, I'm just skipping this one. So this is my summary. Thank you, Sam.
Vishal, thank you very, very much. It's an absolutely cracking talk. We'll get you to do it again next year. Thank you.
Sure, thanks, Sam.
Cheers.
Thank you.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.